Okay, before we even dive in today, I want to test your baseline genomic knowledge right out of the gate. Think about it. Which mutation confers high sensitivity to induction chemotherapy? Is it FLT3-ITD or is it NPM1? Just hold your answer in your head for a second. As clinical pharmacists, distinguishing between these molecular markers isn't just, fun trivia. It literally dictates the induction strategies you're going to be verifying on the oncology floor.
Welcome to The Explainer. I am genuinely so excited to guide you through this material today. We are doing a highly focused, high-yield clinical pathway review of adult acute myeloid leukemia, specifically tailored for you, the oncology pharmacist. We're going to distill all that complex genomic data, the intensive regimens, and, most importantly, the crucial supportive care pearls you absolutely need to manage these toxic therapies safely. So, let's get right into it. Here's our roadmap for today. We'll cover 1. AML risk and genomics. 2. Principles of induction therapy. 3. Consolidation and post-remission. 4. Acute promyelocytic leukemia. And finally, 5. Crucial supportive care pearls. All right, let's kick things off with Section 1, AML risk and genomics. So if you guessed NPM1 for that opening question, you absolutely nailed it. An NPM1 mutation, specifically when it happens without a FLT3-ITD mutation, is a major marker of favorable risk. It confers high sensitivity to induction chemotherapy, meaning these patients generally see much lower relapse rates. We also see a favorable prognosis with CEBPA, in-frame BCOP mutations. On the flip side, though, FLT3-ITD is an adverse risk marker. This mutation basically takes the brakes off, leading to uncontrolled proliferation of leukemic blasts and much higher rates of relapse. The big takeaway here is that understanding this baseline genetic profile is paramount. Actually, if a patient is positive for an NPM1 mutation right at baseline, we're going to track those NPM1 copies throughout their entire disease course to constantly assess for minimal residual disease. Once we have that genomic baseline locked in, it's time to pivot to the actual pharmacological intervention. This brings us to Section 2, Principles of Induction Therapy. Let's take a look at this timeline. Induction kicks off right on day 1. The goal here is simple but incredibly aggressive. We want to clear out the peripheral blood blasts and achieve a complete remission by the time we do that day 28 bone marrow biopsy. Now, your role as a pharmacist during this intense 28-day window is absolutely critical. You're monitoring the patient through severe myelosuppression, basically holding your breath waiting for hematologic recovery. But how do we actually decide what drugs to give them on day 1? Well, that decision pretty much boils down to patient fitness. We stratify induction by intensity. First up, high-intensity induction. This is for your fit patients, usually 60 and younger, or sometimes over 60 if their performance status is great. The absolute non-negotiable goal here is complete remission, and the classic example you'll see is the standard 7+3 regimen. Then we have low-intensity induction. This is reserved for patients who just aren't fit for intensive chemo. Here, the goal shifts from cure to palliation. These treatments, like a hypomethylating agent combined with a venetoclax ramp-up, which, by the way, will definitely keep you busy verifying orders, often just continue until disease progression. Okay, listen up, because this is where your clinical pharmacist spidey sense really needs to be tingling. Modern induction isn't just about standard chemotherapy anymore. We are constantly incorporating targeted therapies based on those genomic markers we just talked about, like FLT3 inhibitors. And you have got to know the rules for these agents. Avoid strong or moderate CYP3A4 inducers, reduce the dose when they're used with strong CYP3A4 inhibitors, and critically, you must avoid concurrent use with drugs that prolong the QTC interval. If avoiding QTC prolonging drugs is literally impossible, you have to monitor those ECGs like a hawk. This is a perfect example of where your specific expertise directly impacts patient safety. Let's assume our patient successfully achieves remission. Awesome, but we can't stop there. We have to move on to Section 3, Consolidation and Post-Remission. I really want this number to stand out to you. 3,000 milligrams per meter squared. That is an absolutely enormous dose. It represents the standard dosing for high-dose cytarabine, or HIDAC, which is heavily utilized in AML consolidation. We are administering this massive dose intravenously every 12 hours for 6 total doses, typically on days 1, 3, and 5. Verifying those giant IV bags is basically a rite of passage in oncology pharmacy. And because the doses are so incredibly high, the toxicity profile is very unique, which we'll touch on in just a minute. But hey, not everyone gets standard HDAC. Let's think back to our baseline genomic risk. A patient's unique genomic profile directly dictates their consolidation pathway.
Favorable risk patients, those with NPM1 or CEBPA mutations, generally receive standard chemotherapy like the HiDAC we just discussed. They typically don't require a transplant during their first remission. However, if a patient falls into the intermediate or adverse risk categories, say they've got that pesky FLT3-ITD mutation, consolidation looks totally different. For them, we highly recommend proceeding to an allogeneic hematopoietic cell transplant, provided they're fit enough to handle it. Next up, we need to shift gears entirely and look at a highly distinct subtype of AML. That brings us to Section 4, Acute Promyelcytic Leukemia, or APL.
APL is defined by a very specific genetic hallmark, the T1517 translocation. This produces the PML-RARA fusion gene. What this essentially does is throw up a huge roadblock on cell maturation. It prevents morphologic differentiation into mature neutrophils, leading to a dangerous, rapid accumulation of leukemic blast cells. It's truly a medical emergency, mostly due to the severe coagulopathy it causes. But here's the fascinating part. Structurally and pharmacologically, it is incredibly sensitive to differentiating agents. Because of this unique pathology, our treatment algorithm completely flips. Check out these options: tretinoin, with or without arsenic trioxide, with or without chemotherapy. What's revolutionary here is that for patients with low and intermediate risk APL, we can actually use a completely chemotherapy-free regimen using just tretinoin and arsenic trioxide. This is a massive departure from the highly intensive 7+3 regimen we use for other AML subtypes, and honestly, it yields a phenomenally higher 5-year overall survival rate. But of course, arsenic trioxide comes with its own strict set of rules. Here is a massive clinical pearl that is going to have you endlessly chasing electrolytes on the floor. Arsenic trioxide is notorious for potassium and magnesium wasting. Before you sign off on any dose being administered, you absolutely must ensure the patient's serum potassium is greater than 4 millit equivalents per liter and their serum magnesium is greater than 1.8. It is an absolute necessity to prevent fatal cardiac arrhythmias, so keep those IV riders ready. All right, we've covered a ton of intense pharmacology. Now, let's bring it all together by focusing on Section 5, Crucial Supportive Care Pearls. Remember that massive 3,000 milligram per meter squared dose of HiDAC? Here is exactly how you manage it. Step 1. You must modify the dose for patients with renal insufficiency. If you miss this, you drastically increase the risk of severe neurotoxicity. Step 2. Actively monitor for cerebellar toxicity. You're looking for mental status changes, delayed fatigue, or somnolence. If a patient shows any of these, get those ammonia levels checked immediately. Step 3. Implement prophylactic steroid eye drops. Cytarabine is actually secreted right into the tears at these high doses, so these drops are non-negotiable to prevent debilitating keratoconjunctivitis. Okay, let's wrap this up with a rapid-fire rundown of the other major toxicities. For hepatotoxicity, conservative dosing is key, especially in obese patients, and you should definitely hold therapy until bilirubin drops below 2. For APL patients, you have got to be hypervigilant for differentiation syndrome during induction, along with severe coagulopathy and DIC, which need immediate supportive care. And finally, for all AML remission inductions, tumor lysis syndrome is just a constant threat. It requires super proactive hydration and uric acid management. Honestly, your vigilant monitoring of these exact parameters is quite literally what makes these intensive regimens survivable. So we've walked through the genomic markers, the induction timelines, the APL differentiation agents, and the vital supportive care steps. I want to leave you with this provocative question to chew on as you head back to the pharmacy. How will you integrate these targeted molecular therapies and all their complex toxicity management into your institution's standard induction protocols? The data is super clear, but the real-world application? That relies entirely on focused, highly knowledgeable pharmacists like you to lead the way. Thank you so much for joining me on this explainer, and I will catch you on the next one.